I am Dr. Vijay Shankar, consulting physician at Mansoor for last 30 years. Today, I am going to present a case of 57 years old male with type 2 diabetes, hypertension with microalbuminuria. 7 years old type 2 diabetes for 4 years. Patient visited the clinic with the weakness in the for last two months. During routine checkup, she complained of generalized weakness. Hospitalized for the chronic sitting 1 year ago. Medication was the metformin 1 gram BD, Ilinotide 4 gram OD, losartan 15 gram OD, atovastatin 40 mg OD, amlodipine 5 mg OD, chlorothiazide 15 mg, metoprolol extra preparation 15 mg daily, and aspirin 75 mg OD. Laboratory findings for the HbA1c 8.2, non-very well controlled. eGFR was 88 minutes per minute, ml per minute. ADLC was the 75 mg per deciliter. HDL was the 37, TG was 156, and total cholesterol was 168. GST was 33 units per liter. CM creatinine was 1.1 deciliter. eGFR 65 per minute, and USCR was the 150 mg per gram. Physical examination BMI was the 32 kg per meter square. BP was the 120/70, and heart rate was 78 per minute, beats per minute. And what to be addressed in this patient? So we have to optimize the glycemic control with the cardiovascular protection or primary treatment consists as HbA1c goal for the many non-pregnant adults of the less than 7 is appropriate on the basis of the provider judgment and patient preference. Achievement of the lower HbA1c level even up to the below 6.5 may be acceptable if this can be achieved without any significant hypoglycemia or other any side effects. Better management during the last two decades allowed the reducing the incidence of CV complications at the residual risk remains high in patients with type 2 diabetes. Security remains a concern, at least partly due to the reduction in the premature death among type 2 diabetes patients. Renal disorders are common in type 2 diabetes, with approximately 50% of patients developing some degree of renal impairment and an increasing prevalence of both conditions over time. The risk of renal disorder in type 2 includes the development of multiple phenotypes of the organs, often overlapping and ultimately progressing, similar to what occurs for the cardiovascular disease. Empiric outcome was randomized double-blind placebo-controlled phase 3 trial involving nearly 7,000 people with type 2 diabetes, almost all of with established CVD. The mean eGFR at the baseline was 74 milliliter per minute, and the median USCR was 18 milligrams per gram. The pre-specified renal outcome in this study included incident or worsening in nephropathy, defined as the progression to the microalbuminuria, doubling of the serum creatinine associated with the eGFR. A main driver of the reduction in nephropathy with the empagliflozin was a slower progression to the microalbuminuria. Hazard ratio was 0.62. Compared with the placebo, empagliflozin was also associated with the significant improvement in the post-hoc composite endpoint of the incident or worsening nephropathy or CV death. The progression to the microalbuminuria and the initiation of a pre-reduction rate with no different RRT with no difference reported between two therapeutic uses of the empagliflozin. Inhibition of the SGLT2 leads to the tubuloglomerular feedback via enhanced natriuresis and the delivery of sodium to the macula densa, thereby decreasing diabetic glomerular hyperfiltration due to the hyperglycemia. Hypoxia to reduce the resulting chronic kidney disease. Ketone bodies are a more energy efficient fuel in the renal tubular cells than the glucose, and as a result, renal oxygen consumption is reduced in the presence of mild ketosis. It has been suggested that the use of ketone bodies as an energy substance in the patient receiving SGLT2 inhibitors may contribute to the renoprotective effect of these agents, similar with the mechanism in the myocardium. DPP4 inhibitors reportedly ameliorate the renal function and pathology in diabetic kidney disease. Enagliptin decrease podocyte process, one feature of the diabetic kidney disease pathology by enhancing insulin signaling. Carmelina study which is enagliptin CV outcome. The study confirmed that enagliptin reduces the progression of albuminuria by 14%, reduce risk for the progression of albuminuria. Moreover, enagliptin demonstrated CV safety, including in patients with the advanced CKD. Enagliptin slowed the progression of albuminuria without affecting eGFR slope or other kidney outcomes. This is a strong rationale for the combining DPP4 and DPP4 and CV protective class SGLT2 inhibitors in patients with the type 2 diabetes. Two drugs have different and complementary glucose lowering effects. Furthermore, increase of the glucagon levels induced by the SGLT2 may be blunted by the coefficient of the DB4 inhibitors. Critical prevalence shows that the SGLT2 and DB in combination is an effective option for the management of diabetes of the omnus obtiat, providing HbA1c reduction of the 1.1% to the 1.115% and weight reduction of the approximately 2 to 3 kg when added to the metformin, which is primarily placed in therapy. In phase 3 randomized trial investigating agency and the safety of the empagliflozin and the linagliptin, better tolerability was observed as a subject who are empalina than those on alone empagliflozin in terms of the serious adverse effects, hypoglycemia, genital infections, etc. This fact implies that the empalina add-on to metformin constitute equal or even better tolerability than the monotherapy with additive glycemic efficacy in uncontrolled patients. This unique combination lends itself related to early treatment in intensification because of good glycemic control and tolerability, possible weight loss, C protection and minimal treatment burden, and offers the renal protection in patients with type 2 diabetes at the high severity. These two drugs they offer most of the omnus obtiat factors. Thank you.